Welcome to everyone with us and those of you joining us via our recording. There was a large meta-analysis that was published in JAMA last week on the relationships between chronic pain, depression, and anxiety. But it was an interesting study, and I'll share a bit what I gleaned from it and start just with some background on chronic pain, because it's something that's quite prevalent and I think presents frequently in our clinical work, either as a topic of treatment and or just as a context for someone who is feeling anxious or depressed. So when something hurts, we'll say, ouch. Raise your hand if you've said that word yet here today. I think I've said it a couple of times. And, Buddhism, the first noble truth in Buddhism is life is suffering. So we say, ouch. Physical pain just comes with the territory of being embodied, having skin, having bones, having muscles that sometimes interact with the world in ways that create suffering for us on the physical front. So the primacy of our expressions of pain seem to be embedded in language. Across every culture that's been looked at, there's an overrepresentation of those ow, ah sounds in words that express physical pain. It's surprisingly robust correlations. And the thinking is that it harkens back to involuntary cries of pain, sometimes called vocalizations, that people around the world have been making for a long time. The fact that there's such commonality in how we express that experience of pain suggests that it is something that has evolved with us, possibly before we actually developed language or speech, before we had these more formal ways of communicating with each other. We were experiencing pain and we were saying stuff like, ow. My dog does something like that. He doesn't say ow, but he'll like yowl, yowl, if he steps on a thorn or something. So I think even across species, these ow, ah sounds travel with the experience of pain. So physical pain is actually not the enemy. It's our best friend forever. If we're living a life and have a rare genetic condition that turns off the circuits that process the nociception coming in from our peripheral nervous system and produces an output that we call pain, we're living in a very dangerous condition. Folks with that disability tend not to live as long or as well as people who have the ability to feel pain. So the brain will produce the output to protect us, and specifically to protect tissue. And it's attempting to do that by changing our behavior. If we sprain our ankle, it now hurts. And our brain would like us to favor the other ankle and limp around for a while to give that sprained ankle an opportunity to heal. Something like that happens with emotional suffering. I think of anxiety, depression, Being outputs the brain creates to protect us. And again, the brain wants to protect us by changing our behavior. If we are behaviorally deactivated, disengaged from the people around us, disengaged from the world, the probability that we're going to live long and prosper goes way down. So the brain wants to punish the choice and wants us to feel bad when we're behaviorally deactivated, hoping that we'll get up off the couch and start doing things, a choice that it will reward with more positive emotions. Of course, we can see anxiety being a protective output as well. If we're getting near the edge of the Grand Canyon to look down and see the very bottom, we might start feeling some anxiety as we do that. And clearly here, it would be an effort on the brain's part to change our behavior. Stop walking towards that cliff. Maybe stay where you are or actually walk back a bit. And when we did that, the brain would reward that more protective behavior with a feeling of relief or relaxation or something else. So this physical suffering, physical pain, and emotional suffering are the brain trying to keep us safe, trying to be helpful. And in fact, there's a lot of neuronal overlap in brain processing of physical and emotional pain. Both of the experiences apparently are mediated by inflammation. That the HPA axis, the hypothalamus pituitary adrenal axis, is central to the experience of both physical and psychological suffering. And there are some interesting studies where non-steroidal anti-inflammatory drugs turn out to be anti-anxiety drugs. I would not have made that connection, but the data makes that connection. For certain cohorts who are feeling anxious, taking aspirin will reduce anxiety, likely because of this neuronal overlap in how the brain processes both forms of suffering. So a little bit more about the actual mechanism of physical pain and its relationship to chronicity, how pain in the moment would actually become chronic pain. So it begins out at the edge of our peripheral nervous system, where we have these nerve cells that sense potentially dangerous changes in tissue. There are three principal kinds. They would sense changes in temperature, changes in pressure, and changes in pH. We don't have pain sensors in the peripheral nervous system or anywhere else, but we do have these nociceptors, they're called. And those are the three things that they would be monitoring. So the messages get sent from the nociceptors to the central nervous system, starting with the spinal cord, where they're first sorted by the dorsal root ganglion, the structure in the spine that I sometimes think of as the most peripheral brain, because the ganglion take the messages, evaluate them. Some they would just not pass on. They would make the decision that is not salient information for the whole organism. Others they would sense are urgent or are important, and they would send them on up the chain of command into the brain. The brain then would take those messages and process them, first of all, in the brain stem. The same sorting would take place there. The brain stem would say, I think we can ignore this, and that would be the end of things. Or it could say, this seems important. We're going to send it on up. The next stop would be the limbic system, where again, a decision would be made. I'm going to get emotionally activated because of this data. I'm going to start feeling worried, anxious, panicky, or not. Then, if the limbic system says, yeah, this is a time to become anxious, it's going to send that message further into the cortex and into the motor circuit of the brain, where we'll have the thought, I better take a step back, and that will activate that behavior and protect the entire organism. So this whole process is going on for all of us 24/7. We're always getting this messaging in from the peripheral nervous system. And it's always being evaluated, first of all, in the spine, and then by these higher centers in the central nervous system. And it would occasionally create that ouch experience. For the most part, not. Most of that messaging is not considered salient. And so it dies at one of those lower centers. So that would be the experience of stepping on the nail or spraining our ankle, right? But this other thing can happen where a particular experience of pain becomes chronic. And usually chronic pain is understood as pain that has stuck around for at least 3 months. So it's not a sore back that we say, ouch, when we get out of bed in the morning. It's a sore back that has gotten out of bed with us every morning for at least 3 months. And the data says that as many as 1 in 3 of us are suffering that kind of pain. It can be muscular pain. It could be joint pain. Might be nerve pain. Or it might be skin pain of some kind. And when pain becomes chronic, it starts to become pretty slippery diagnostically. So you've probably heard words like fibromyalgia or conversion disorder or psychosomatic pain. And one line of thinking is we have all of these long words because we don't really know what's going on much of the time that someone's in a chronic pain state. So we'll come up with a new word for it and hopefully conduct some research that would say this new way of looking or describing pain is actually helping people or not. So chronic pain's a big deal. It's regularly in the top 10 of all global disease burdens each year. Costs the U.S. upwards of $600 billion a year to address. It, of course, was one of the principal drivers of the opioid crisis that we're hopefully now beginning to exit from, and creates a lot of disability, missed work, and so forth that also has follow-on economic costs. So when we're looking at chronic pain, we can sort it a bit by its location in the body. Most of it is low back pain. About 30% of all chronic pain states are pain in the lower back. The next is knee pain. The knee is a vulnerable joint, and walking around and jumping and climbing over things and falling down oftentimes produce an initial injury that could then become a chronic injury. Next on the list is headache, which would include migraine. About 16% of chronic pain is head pain. Right below it at 15% is neck pain. Oh, my aching neck. And of course, those two pain states would be very interrelated, be talking to each other. So those of us who experience chronic pain would bring to that vulnerability certain factors, which include genes. I don't know that we've identified the specific genes for specific chronic pain states, but we have seen that chronic pain is a highly inherited condition, which does not mean if our mom had pelvic pain that we are sentenced to have pelvic pain. It would simply mean that we have a higher probability of developing that condition than if mom hadn't suffered in that way. A history of trauma can sensitize us to an experience of chronic pain. And there are a lot of social and interpersonal factors that come into play. When we get into the data portion of the paper, we'll talk about that a bit. And this state of being in chronic pain is comorbid with a lot of psychological disorders, principally anxiety and depression. So what's happening in the central nervous system when pain is no longer an acute experience, but becomes chronic? Well, one of the things that happens is called central nervous system sensitization. I think in the paper, this was called something else. Oh, nociplastic pain. I've not seen that word before, but basically it's talking about changes in the structure and function of the spinal cord. So these structural and functional changes basically make the messaging system better at sending nociception up to the brain, and the brain getting better at creating the output of pain. The sensitization part relates to the actual change in the structure of the neurons. They have more interface to send messages, so more messages get sent. And the brain, being a very plastic organ itself, goes, gee, we're getting a lot more distress calls from down below. This must be dangerous. So the brain increasingly produces the output of pain. And the unfortunate dynamic here is that more and more nociception creates more and more pain, such that for some chronic pain folks, just imagining moving in a certain way will produce the experience of pain in the neck, in the head, in the knee, in the back. Just the thought is threatening enough that the brain will respond by creating this. The other thing that happens is someone who, say, hurt their knee and paid attention to staying off of it, but is not doing physical therapy, is not inviting themselves to actually stretch and strengthen the structures surrounding that, will have a chronic pain experience of less and less movement being required to produce the same level of pain. So there's a behavioral deactivation that goes on. And we know that joints like to move. Physical therapists sometimes say motion is lotion. If something is sore, we want to move lymphatic fluid through it. We want the blood getting in and cleaning up the damage that's been done and new tissue being regenerated and so forth. So the less we use something, the more we're setting the stage for any use of it being a painful use. So let's pivot here and look at some of the data came out of the JAMA study here. It confirmed that the prevalence in the population is about what I was describing to you based on earlier studies. As many as 1 in 3 or 1 in 4 of us are currently or have been in a chronic pain state that has persisted for at least 3 months, oftentimes 3 years, sometimes 30 years. People will sometimes come to me after suffering chronic pain states for decades and getting all of the tests, all of the procedures, but no relief, or the relief that they would get would be transitory, feel a little bit better for a while, but then right back to the old condition, which I think, based on what I've described in terms of this interface between the peripheral nervous system and the brain, we could begin to appreciate why that might be happening. So one of the takeaways from the paper was that after accounting for a lot of biopsychosocial factors, being depressed or being anxious are among the best predictors of being in chronic pain. Let me say that again, because it really landed with me. We're not talking about physiology here. We're not talking about imaging, not talking about all of the other ways into predicting or diagnosing chronic pain states. The emotional painful states of depression and anxiety are among the best predictors that we have that someone is or will be in a chronic pain state. Depression and anxiety are themselves leading causes of disability, contributing to reduced quality of life and reduced life expectancy as well. If we're anxious and depressed, we don't live as long as someone who's not living in those states. So what the data is getting at is that up to 40% of adults who have experienced pain in the same region for 3 months or more are also anxious and or depressed. That's a lot of people. We could almost say that there's a transdiagnostic quality to this data. If someone has been anxious and depressed, the probability that they will be in chronic pain goes up significantly. And if someone's in chronic pain, the probability that they will be anxious and depressed goes up significantly. These three travel together. And the paper points in the direction of some shared neuronal circuitry here as well. Specifically as relates to anxiety, the HPA axis can become increasingly sensitized. And that is an axis that is implicated in the fight, flight, freeze response. And it's also the axis that is activated in a pain experience. So the better the HPA gets at putting out these outputs, the more vulnerable someone who's in a chronic pain state would be to also becoming anxious, elevated heart rate, higher blood pressure, elevated cortisol levels, and so forth. And the converse would also be true. Someone who's in an anxious state and sprains their knee is more likely to experience chronic pain as a result than someone who's not anxious at the time that they hurt themselves. The study found that statistically, the prevalences of depression and anxiety were highest among younger people and women. And they didn't try and explain that. That was beyond the scope of the paper. But I think it's significant for us as clinicians to bear in mind when we're thinking about the linkages between physical and emotional suffering. We might want to think first of treating, teenagers and treating women of any age. The prevalence of depression and anxiety was the highest among people who were suffering chronic pain in the direction of central nervous system sensitization, or as the paper calls it, nociplastic mechanisms. And this makes sense because they call out fibromyalgia, complex regional pain syndrome, temporal mandibular disorder, and so forth. These travel with the structural and functional changes in the body that would create and maintain an experience of chronic pain. And as you could probably imagine, the clinical symptoms of anxiety and depression were greater among the samples of people who had longer pain durations. This also points to the question of directionality when it comes to chronic pain, depression, and anxiety. The directionality might vary based on an individual experience. It could be that being depressed and anxious makes us more vulnerable to experiencing chronic pain. And it could also be that being in chronic pain raises the probability that we'll be anxious or depressed. We're not working, we're not making money, the bills are piling up. Of course, we're going to be more anxious and worried as time goes on. Perhaps also more depressed, more hopeless and helpless, thinking, I'm never going to get my life back. This physical experience of being embodied is proof that this is all that I can expect for the rest of my life.